My name is Antonella Scali. I'm the Executive Director of the Canadian Psoriasis Network. Welcome again to our actually our last event for 2021. So we're excited that you could be here with us tonight. Just before we actually get started on the presentation, I do have to go over some brief housekeeping, and I do have some additional information that I wanted to share with attendees about a very exciting event this week, which is World Psoriasis Day on Friday, October 29th. So I'm going to take a little bit of time just to give you some information, and then I can't wait to turn it over to our presenters tonight who are excited to have with us. So just as a reminder, the webinar is being recorded in English and French, and as with all of our webinar events, the session will be posted on our website in both languages for viewing in the next few days. So you can see that on cpn-rcp.com. All participants for this reason are in listen-only mode for the duration of the session. So if you have any questions, as you kindly did earlier, please type them into Q&A, and we'll be sure to get to them at the end of our presentations tonight. And I do have to mention, as with all of our webinars and resources, the information presented tonight is general information only. So any specific questions and specific concerns, our speakers won't be able to speak to your personal circumstances. We encourage you to talk to your doctor about any questions about your condition, including the risks and benefits of any care or treatment for you. Again, the information shared by our presenters is based on their personal and clinical experience. It's a great experience. We're very lucky to have our speakers tonight. And so we just want to make that clear that they won't be able to answer any questions necessarily pertaining to your unique needs or unique case. I want to acknowledge that this webinar is made possible through an educational sponsorship from AbbVie and support from Ducret. We're very grateful for the support we get for these events because we're able to dive into topics that are important to our communities, and we're able to do that with unrestricted support from our funders. So we're very grateful for that. I do also have to mention, because there is going to be mention of treatment tonight, that our sponsors don't support product discussion that's not consistent with the approved prescribing information in official product monographs. Not that we're going to necessarily be talking about that, but just in case, we do have to mention that because it's required. So just a little bit, as I mentioned, about our organization. Many of you are probably members, but for those of you who aren't, we encourage you to check out cpn-rcp.com and consider joining us as a member. It is free, and we keep you abreast of information about the psoriasis and psoriatic arthritis landscape in Canada with member-only content and newsletters. You're the first to know about events like this one as a member. We also encourage you to follow us on social media if you don't already. As I mentioned, we're really excited because World Psoriasis Day is this Friday. So it's a really important day for our community to raise awareness, to get the message out about the needs of our community, and to connect with people. So I'm very excited to share that this World Psoriasis Day, so look out for it on Friday, CPN is going to be launching a collaborative report with two of our partner organizations on the workplace needs of people with psoriasis and psoriatic arthritis in Canada. So the report is going to have tools as well and resources for people who are navigating workplace accommodations or needs in the workplace. So we're really excited about that, and we encourage you to follow us so that you get that information when we launch it on World Psoriasis Day. Hopefully there will be some information that's useful to you there. And thank you to everyone who completed our survey to help inform the report. So we really, again, take from our community and give back to you what we can in terms of information and resources that you're looking for. So with that, I am very excited again to turn it over to our speakers tonight. I have a very brief bio to present them, but before I do, I just want to mention that tonight's topic, so difficult to treat areas, is one that we hear a lot about from our members and our broader community. We get questions all the time about persistent symptoms that even when treatment is going well, generally there are some persistent areas of the body that can be harder to treat, that can be more physically and mentally and emotionally draining, depending where on the body the psoriasis presents itself. And also that can be harder to talk about. So, we know that genital psoriasis is not uncommon. It affects people. And sometimes this is overlooked when you're actually in the clinic with your nurse or your doctor. So we're hoping tonight is an opportunity to have our speakers dive into these special areas of the skin that are impacted, do some demystifying if you have questions about treatments or about concerns about how these symptoms manifest, and give you an opportunity to ask questions and to kind of hear from the experts on how to work with your care team to address some of these common needs. So with that, I'm very excited to turn it over to our speakers. And I'll introduce them both, and there will be time for question and answer at the end, like I mentioned. So please do pop your questions in, and we will make sure we get to them after the presentation. So first, Dr. O'Toole is a dermatologist with the Skin Center for Dermatology. I'm going to stop sharing my screen so that I can turn it over to our speakers. So she's a dermatologist with the Skin Center for Dermatology in Peterborough, Ontario, where she also serves as a sub-investigator for multiple clinical trials. She's an adjunctive professor at Queen's University and involved in teaching medical students and residents and holds medical privileges at the Peterborough Regional Health Center. After receiving a Master's of Health Science in Health and Behavioral Communication at Ryerson University in Toronto, Dr. O'Toole received her medical degree from McMaster University in Hamilton and completed her residency in dermatology at the University of Ottawa. Dr. O'Toole is the author or co-author of over 20 peer-reviewed publications and has been involved as a sub-investigator for over 40 clinical trials on atopic dermatitis, psoriasis, alopecia, acne, and vitiligo. So welcome, Dr. O'Toole. Thank you. This is a wealth of information that you're bringing to us, so thank you so much. And I'm very excited to introduce your co-presenter, Julie. I should have asked you this first, but Buchan?
It's Buchan.
Buchan, okay, Buchan. Thank you. Julie Buchan is a registered practical nurse who has been working with the Skin Center for Dermatology for over 15 years. She has a wide range of experience in managing patients with psoriasis, including phototherapy, and has attended many international conferences in dermatology to advance her skills. Thank you so much, Julie. We're grateful to have you both here. I will turn it over to you to start your presentation, and I look forward to questions when you're done.
All right. So I'm just going to try share screen here. And everyone can see that? Perfect. All right. So thanks for the kind introduction. I'm Dr. Ashley O'Toole, and again, Julie's beside me. And we're really excited to present to you guys. Looks like we have a big and awesome audience, so that's awesome. Thanks for giving up a part of your night tonight to learn a bit more about psoriasis. And thanks to our sponsors and Anatella and the Canadian Psoriasis Network for hosting tonight. And these are our acknowledgements. Again, thanks for everyone for giving a part of your night. So just for an overview for what we hope to cover this evening. So we'll start with an overview of what psoriasis is, and then we'll be spending a good portion of tonight talking about treating psoriasis and how it presents in special sites. And some of these we've already mentioned, including the scalp, face, nails, palms and soles, and genitals. And then we'll talk about ways that we would recommend optimizing the management of your care, not only with your dermatologist, but how that can be optimized working with your nurse or your pharmacist and your whole healthcare team to really make the best of the psoriasis experience. So I'll let Julie start with our overview.
Okay, so psoriasis, an inflammatory disease affecting up to 4% of the population. It's caused from an inappropriate immune response, constantly stimulating the growth of new skin cells. May be associated with joint inflammation known as psoriatic arthritis in up to 30% of people with psoriasis. The way that it presents, it may be red and scaly. It could be plaques or papules. Could be on the scalp, the legs, the torso, the arms, the hands, feet. And presentation of disease may differ in areas of the body, such as under the breast, the groin, and the nails. So psoriasis has a significant effect on a quality of life for each patient. Psoriasis has been associated with increased depression, anxiety, loss of work or difficulty obtaining gainful employment, lack of sleep, and lack of concentration. And we've heard all of these things from our patients in clinic. Other associations with psoriasis. So some patients can be associated with metabolic syndromes such as diabetes type 2, increased cholesterol, high blood pressure, obesity, fatty liver disease, psoriatic arthritis, inflammatory bowel disease, eye disease, and kidney disease. So it's very important to ask your patients all of these questions as general well-being during the screening process. So signs and symptoms, again, could be presenting as red, small or large patches of skin covered in scale. Sometimes as a thickened silvery plaque may be present. You could see dry and cracked skin, especially on the palms or the feet. Patient can report itching or burning, which may be associated with the plaques or the papules. You may see swollen joints in the fingers or the toes if associated with an inflammatory type of arthritis, again known as psoriatic arthritis, thickened or discoloration of pitting of the nails. Again, these are all the reasons why we do have to see our patients in-house and have them undressed and looking over all parts of the body, because you could miss something if they leave their socks on, put shoes on. So causes of psoriasis, that's a very common question that we get, and it's very hard to answer that. It's kind of multifactorial. So it's a chronic autoimmune condition that causes rapid buildup of the skin cells. It could be associated with medications or bacterial infections such as strep throat. There may be a genetic predisposition. Known triggers, but not a sole cause, may include stress, smoking, alcohol, injury, severe sunburn, extreme cold or dry weather conditions.
Perfect. And I'll just add a couple things here about these triggers, because Julie's so right in how she said that patients or their family members are often asking, well, what's causing this? I never had it before. And we know that there's kind of two main periods where psoriasis can present for the first time. So it's not something that some people are born with, but it usually presents for the first time in either the 20s to 30s or 40 to 50. And the point here about the genetic predisposition, about 50% of patients do have a family history. So whether that's, in their mom or their dad or aunt, uncle, grandparent, sometimes if you go back in the history, they may have a positive history in their family, but sometimes not. And then the other triggers like we have listed here. So stress can be a huge trigger. So it's not uncommon that someone who's gone through a stressful period will present and all of a sudden now they've got lots of psoriasis all over. And same with other things that are injurious to the body, like smoking, alcohol, even an injury or trauma to the skin, and the sunburn, like Julie mentioned. So it's just a nice kind of summary there. And then this is sort of a basic treatment ladder that will take you through things that maybe you've used before, or things that your doctor or family doctor, dermatologist has mentioned, but it's nice to have them all kind of in one place. So the ladder usually begins with topical treatments, things like topical steroids that are quite commonly given at the first appointment. And then we do know that vitamin D is quite effective for psoriasis. And I always tell my patients that vitamin D, very natural. It's actually made from sunlight. And so companies have been able to come up with a topical version of vitamin D, which is quite effective for psoriasis. And I tell my patients it's like putting on topical sunlight. And then there's topical calcineurin inhibitors. These baby things that you've heard of before, like Protopic or Elidel, they're more commonly used for eczema or atopic dermatitis, but we do use them in special sites, which you'll see coming up. And then what the industry has really moved for in treating psoriasis are these combinations. So there's lots of new combinations that have been approved for psoriasis. So I wrote down here, so there's a topical vitamin A combined with a topical steroid, and that one came out last summer, and that's called Duobri. So that's a new lotion that's approved for psoriasis that you may or may not be aware of. And then other combinations would be using that topical vitamin D again, and then combining that with a steroid. And those are products that have been around a little bit longer. So Dovabet gel, Dovabet ointment, or Enstellar foam. Those are examples of that nice combination. And we know that these combinations can sometimes work in synergy to make it work better for patients. And then the next step in the ladder, which is available in some clinics, and we'll spend a couple slides talking about how this works, is called phototherapy. So again, we talked about how topical sunlight can be helpful. Phototherapy is basically medical grade sunlight, or almost like a medical grade tanning booth. So this can be UVA, so ultraviolet A waves, ultraviolet B waves, or broadband. So that's when it's both UVA and UVB. And it can be delivered in a clinic setting, or there's home units. And so we often get a lot of questions about this because it's something that a lot of patients have never heard of before when it comes to treating psoriasis. So what is phototherapy? So sometimes it's located in a dermatology clinic. We're lucky at our clinic in Peterborough that we do have a couple phototherapy units. And it's also sometimes available in a larger hospital. And then when it's given in our clinic, or most medical clinics or hospitals, it's covered under OHIP. So it's usually covered under provincial insurance, the treatments. And then some physiotherapy centers also provide phototherapy, but that coverage may be dependent on someone's insurance. When a patient comes for phototherapy, they can have whole body exposure, which you can imagine is something that's done in the unit picture on the bottom there. They kind of step into the machine, sometimes wearing a towel, sometimes wearing gym shorts and a tank top. Wherever they have psoriasis, the light will be affected. So they can be a whole body exposure, or a handheld unit if someone just has particular areas they want to target. Or then the photo above is actually showing a hand and foot unit. So the lady sitting there has her hands in a machine where she's exposing hand psoriasis or hand eczema and foot psoriasis and eczema to the UV light. Sometimes the phototherapy is prescribed alone, or sometimes it's actually with a thing called Psoralen, which is a medication which can be in a bath or in pills. And that's done in even more unique centers, usually at a hospital. So we don't offer this in Peterborough. I tell my patients that it's a pretty simple and easy treatment. Usually when they start, they'll start at like 15, 20 seconds of phototherapy. Julie used to run our machine in Peterborough, so she's seen many patients through this. And then each visit, they increase the amount of time that patients are using the machine up to a few minutes at a time. And that gradual exposure leads to really good and safe results. It usually works best if a patient is able to come for 2 to 3 visits a week. And again, it's minutes at a time. And usually it can be worked like pretty flexible around the patient's schedule. Sometimes they come on their lunch hour or after work. So it's meant to be a pretty simple treatment. And again, they can expose all the affected areas. And some private insurance companies will actually cover a home phototherapy unit. You can imagine these are pretty expensive for some patients. You know, the handheld units ranging from, you know, $500 to $800, but a home booth is like $5,000 to $10,000. But we've worked successfully with a few insurance companies to get people these when it's not something that is practical. You know, if they live 2 hours away from the clinic, so it's something that can be done.
And they do have refurbished units as well that can be a little bit more cost effective for patients. And there's a website, we'll put it at the end, but it's called solark.com. And that's a site that you could go to look up, and they have refurbished units as well.
Yeah, that's true. And sometimes at our clinic, someone will be done with their machine or have had a partner that maybe passed away. And sometimes we'll be able to tell patients who are looking. So if you ask around, you could find these things out, which is great. Okay, so moving down our ladder, so we covered the topicals there, and then we spent some time chatting about phototherapy and how that works. And then we'll get into more of the medications either by mouth or injections that we use for patients who have more moderate to severe psoriasis, or psoriasis that hasn't responded to the topicals, or if they're not able to come for phototherapy. So when it comes to a traditional systemic, these are medications that have been around for, 30, 50 years. They're tried and true. They work quite well. And a lot of them do require monitoring and can have side effects. So they're things that many family doctors at that point definitely refer to a dermatologist for that extra training. So just in general, the first one I have listed here is called acitretin. The other name for this is Soriatane, and it is an oral, so it's a pill, vitamin A. So we mentioned earlier about how vitamin A can be effective topically, so it's also effective by mouth for psoriasis. And I think of this as a nice, pretty safe option. And it works by slowing down how fast the skin's turning over. So Julie mentioned that psoriasis, the plaques on the elbows or the knees can build up because that skin's turning over on average about 4 times faster than the rest of the skin. So acitretin helps to normalize so that the skin turns over about the same. And so it's a nice option. Methotrexate, which is the medication listed in the middle there, that's another very tried and true, quite effective treatment. It is also a pill, but it does come in an injection format. And that's a once a week medication. Quite effective and also used for arthritis, like Julie was mentioning. So it's quite effective in psoriatic arthritis, rheumatoid arthritis. So some people may be on that or have had experience with that. And then the last one here is called cyclosporin. That is another medication by mouth. It's a once a day medication, quite effective. And I do think of this one as the medication that offers probably the fastest result. So I've had a couple of patients where they come in and then they've had a stressful event, or, the classic patient that I always think of is this young woman who was getting married. So she was very stressed, and then her psoriasis was horrible, and the wedding was weeks away, and we wanted to fix her quickly. So we thought she needs cyclosporin, and sure enough, it worked.
Yes.
It didn't work forever, and she did need to move on to other medications, but that's one that you may have heard of as well.
We kind of say it's the rescue drug.
Yeah.
So if you need something fast to work, that's your medication.
Yeah, agreed. And then the last part of the ladder here, or the top of the ladder, is the biologics, which are things you've probably maybe seen television commercials on. So these are usually injectable medications. There are some oral medications out there. Often these medications do need patients to try and fail the more traditional ones listed above. But there's many medications that are coming out. I think there's 12 or 17 out there now that are in the pipeline. Things like adalimumab, etanercept, ustekinumab, secukinumab, ixekizumab, lots of mAbs, risankizumab, and gozulkimab. And the word mAb means monoclonal antibody. So it's a humanized, usually injection, that helps to tame down part of the immune system that's driving the psoriasis. And the attempt is to leave everything else functioning as normal and just lessen the overactive immune system driving the psoriasis. And there are some upcoming and already existing oral medications on the market that are considered biologics. And so the one that you may have heard of is called Apremilast or Otezla. No, that's a heavy slide.
And just to go back to the traditional systemics, one thing I did want to mention with the acitretin and the methotrexate, it can take a few weeks before you start to see some improvement with the psoriasis. So we often tell patients really give it about 3 months before we abort therapy.
Right. Yeah. Okay. So now we'll go into part of the focus of tonight, which is examining the special sites that can have psoriasis and ones that are traditionally more difficult to treat and what we can do about them.
So nail psoriasis, that's probably one of the trickiest areas to treat, and often takes several treatments before we sort of get it right. So it's definitely not one that's the easiest to treat, but certainly challenging. We're always up for a good challenge. Scalp. Palms of hands, that's another one that's can be very challenging, and there can be a lot of variance in the presentation. So sometimes patients will even present like this picture showing with pustules, and oftentimes when patients present, they think maybe it's something they've had contact with, or maybe they have a fungal infection. So anytime you ever see anything on the palms, always a thorough workup with investigation and history. Mm-hmm. So facial psoriasis, that's always a very complex scenario with patients because it's very embarrassing, makes somebody very self-conscious. All these areas, in fact, create anxiety. And then soles of the feet, the toes, the shins. So scalp psoriasis, so about 45 to 56% of people having involvement with their scalp. And as you can see in the photo, it can present as very thick plaque that's covered in a fine scale. Sometimes it can be very mild, just pink in color, and maybe just even a little bit of mild dandruff. And a lot of people will just think, oh, I have a little bit of dandruff, I might be a little bit itchy, but maybe not recognize it to be psoriasis when it's sort of a mild presentation. You may also see ears affected, posterior neck and forehead. And again, sometimes it presents a little bit different on the face as just like mild pink, like patches or macules. Certainly scalp and facial involvement creates a lot of embarrassment and social isolation. And it may be related to scalp psoriasis due to itch and flaking of the skin, or the skin kind of flaking onto their clothing, and just being constantly aware of that can make you very self-conscious. So treatment of scalp psoriasis, it could range from topical lotions or gels. You can get like over-the-counter shampoos for psoriasis and prescription shampoos. Again, like Dr. O'Toole was saying, systemic agents or biologics, so medications that we take by mouth or by injection. And certainly with these areas, there's definitely special consideration for face and scalp psoriasis, as some medications may be causing undesired effects. So, you know, if you were using a topical steroid on your face, obviously a strong topical steroid can cause undesired effects like glaucoma. It can cause thinning of the skin, and acne. So you definitely have to take all those factors into consideration when you're choosing a topical. So systemic medication options could be phototherapy, intralesional steroids. So using a steroid instead of topical, you actually inject a plaque. And that can be actually quite beneficial. And sometimes patients will only have sort of one isolated plaque. A patient may come in with a plaque just on their scalp and nowhere else, and maybe not motivated to take something by mouth. Intralesional injection of steroid can actually be quite beneficial and work quite well. Again, going back to the systemic medications, so Soriatane or acitretin, cyclosporin, and or methotrexate, and then biologic agents.
I'll just add one little point there about phototherapy for scalp. It is probably one of the most difficult areas for the light, like the UV light, to penetrate. We have some men in the clinic who's like, well, I want it gone, so can I just shave my head and then use the light and it'll work better? And certainly that works better, but it's not ideal for a lot of patients to shave their head. But there is this thing out there that I've heard at clinics. I don't think I've met anyone myself that's used it, but there's a UV comb. Oh. So it's a comb that you can, I mean, you must be able to turn it on and provides UV light for affected areas. So there's, you know, the industry is always changing. This is definitely an area that causes a lot of social embarrassment and angst for a lot of patients. So it's kind of interesting that there's even new things coming out every day for that.
And then facial psoriasis, again, so about 50% of people with psoriasis will have it on their face. And it may appear with pink or red in color, it may have a scaly appearance, and it may cause some itch. Oftentimes with psoriasis, in my opinion, and Dr. O'Toole, you might want to add to this, I find that patients don't really report a lot of itch with psoriasis necessarily. Maybe atopic dermatitis or eczema, yes, can be very itchy, but not as much psoriasis, especially on the face. It's more the appearance that creates interest in having treatment. Given this is the first area that people see, obviously it's very embarrassing, and patients are really upset, want this treated right away. High social and emotional impact of facial psoriasis. So some biologic medications may make it easier to start for patients who have facial psoriasis. So in other words, some medications are easier to get depending on the area of involvement. And we have a lot of amazing supportive companies that work with our clinic and any other clinic who prescribes these medications. And it can be a way to eliminate some of the hoops that you have to go through with insurance companies. So treatment of facial psoriasis, treatments are somewhat limited due to the sensitive nature of the tissue. So oftentimes we'll prescribe, like Dr. O'Toole was saying earlier, a product called Protopic or Elidel, which are non-steroidal anti-inflammatories. And they're very safe to use on face and folds of the skin. You can also use gentle cleansers that can be found even over the counter, phototherapy, non-steroidal anti-inflammatories, like I just said, and mild topical prescriptions, oral agents, or biologics.
Perfect. So I'll take us through how nail psoriasis can present. Very common, and sometimes patients don't even know that they have it. But you know, when we're seeing a patient and we want to cinch the diagnosis, sometimes examining their nails, then you can start to see some of these key features, and it helps you make that diagnosis. So about 50% of people who have psoriasis do have it in their nails. May only have one nail that's affected, or it can be all 20, like all fingers and all the toes. We know that having nail psoriasis, especially if it's severe, can be an indicator for psoriatic arthritis. And it's usually in the affected digit or finger where the nail is affected that those joints may actually have the inflammatory arthritis there. So again, it's something that we keep in mind and we always examine, and it helps you determine what treatment might work best. So this photo here shows some of the key indicators of nail psoriasis. So the nail itself can look yellow or brown, kind of discolored. That's called in our derm textbooks called the oil drop sign. So it looks like a bit of greasy oil under the nail, can be thickened, and then sometimes you see tiny dents. So if you look closely there, you can see lots of tiny little pits within the nail, and that's a classic nail finding. And there can be lifting or separating of the nail from the skin. It's kind of interesting because patients are often referred to us or treated by their family doctor for a fungal infection, and there are a lot of overlying features, and I think that's probably one of the most common misdiagnoses is it fungal, and when it's actually nail psoriasis. And because we use our hands and we're shaking hands all the time, having nail involvement is quite a social embarrassing issue for patients. They often may want to hide their hands or avoid doing certain jobs, such as being a cashier, to help avoid questions from the public asking, what's wrong with your nails? Are you contagious? Do you have an infection? So it's quite a common problem. Treatment of nail psoriasis, as Julie alluded to, very difficult. Occasionally we try a potent topical steroid or a combination agent around the nail plate, like around, like onto the skin. Sometimes that works well under occlusion if someone wraps it or puts it in a bandage, and that's the best topical way to treat it. But usually you either need to do something intralesional, like an injection, or sometimes patients are moving on to oral therapy or biologic agents. I would say that the intralesional steroid, so that's using a needle to inject a steroid right into the
right in here.
right into like where the nail matrix is. Very, very painful. We have some patients that are up for the challenge and it works amazing and it works like a charm, and they come back, but more than half are like, I will never do that again. So it's potentially not a good long-term option, but it is something that can be used. But in many cases, we're moving on to oral therapy or biologics for these difficult cases. And then palms and soles. So a less common area to find psoriasis is on the hands and feet. About 12 to 16% of patients who have psoriasis do have it on their hands and feet. And it can appear like red, pink, scaly, cracked, but it can even look pustular. Like it can look like little whiteheads under the skin of the hands. Fissured, as you can see in the photo here, or just thickened skin. So it can have a lot of different presentations. And so looking for other key features, like checking out the nails, checking out the scalp, or the common areas for psoriasis like elbows and knees can help you make the right diagnosis. Certainly you can imagine that this person's hands are definitely affected with pain and loss of mobility because the psoriasis is so disfiguring and painful for them. So definitely has a huge quality of life impact. So obviously we want to treat it. So as providers, whenever we're writing a prescription, we want to know how that topical is going to feel, because it's going to affect the hands or how the patient's going to feel inside their shoe wear. So certain topicals or agents are better than others. This is an excellent area that responds quite well to phototherapy. We had a photo earlier of the hand and foot unit for different patients, so that way they can just get targeted treatment to their hands and feet. Topical steroids and non-steroid topicals like the Protopic or Elidel can be effective here. Often patients get worried when we talk about using like a potent steroid on the hands and feet because they're worried about thinning of the skin, which is definitely a risk when you're treating more thinner sensitive areas, but the hands and feet, as you know, are very thick and hardy. So we do feel comfortable using potent steroids on these areas. And again, many patients do go on to need oral or biologic agents for these groups. And a lot of drug companies, as we mentioned, are aware of the impact on quality of life and what it does to affect a patient. who has hand and foot involvement, and they do allow it to become a little bit easier to get them on these medications. So it's nice. And then we also alluded to this a bit earlier, how impactful it can be to have genital psoriasis. It's way, way more common than we think. So up to 66% of people, so 2 in 3 people who have psoriasis can have it affecting the genital area. And this can be anywhere from the inner thighs, the buttocks, and the genitalia itself. And it's definitely a case of if you don't ask for it and you don't look, you'll never know. Even today, I had a lady that came in with a completely separate rash on her legs. And I was looking through her different medications that she had tried just in her letter from her family doctor. And I saw that she had been given an antifungal. And I said, oh, is that for your rash on your legs? And she's like, oh, no, I'm actually using that in my genital area. I have, a fungal infection that just won't go away. And I've tried so many things. And I said, can I have a look? And it was classic, like inverse psoriasis or genital psoriasis in this area. And, if that hadn't come up just by looking through her old medications, she would,
she probably wouldn't.
It would be untreated. And then she just started crying and she said, I'm so happy I'm finally getting an answer for this. And I've been so embarrassed about it. So yeah, as healthcare providers, we definitely need to ask, and you hopefully as patients and family members feel more comfortable that there's options that are out there to treat it, and we're more than willing to listen and take a look.
Absolutely.
And it doesn't only affect the patient themselves, it also obviously affects the relationships, and some patients avoid having intimate relationships because of it. So it's just nice to know that there are treatments out there. And again, because the genital tissue is so gentle and sensitive, there's lots of nice, safe options for treating there. We know that there's safe topicals, so sometimes we use low potency topical steroid or off-label use of topical calcineurin inhibitors that don't have any steroids, so those are quite safe. And then again, many oral or biologic agents are available and quite effective for this area.
Okay, so management of care. Each site is very important when deciding on treatment options, as we kind of just went through. So considerations when deciding on treatment modalities. So if you think about how easy the topical will be to apply. So for instance, if you have an elderly patient that can't reach their back, is that going to be something that's going to cause lack of adherence to the product? The cost of the drug. So maybe that patient doesn't have drug insurance. I can say in our area, majority of our patients do not have drug insurance. So that's something that we really have to ask our patients about. Each patient that comes in, we ask about insurance, because that's going to, of course, direct our thought process depending on availability of medication with or without drug insurance. Accessibility. So if someone's coming for phototherapy, we service a huge area around Peterborough. So some of our patients, we had a lady in from Bancroft today, and she was quite happy to come to phototherapy. You would think it would be too far, but she was quite motivated. So phototherapy, if a patient is close enough, that's certainly important to think of. Potency of medications. So especially all the sensitive areas. So face, folds of skin. So folds of skin would include the axilla, so under the arms, under the breasts, in the groin, genitalia, between the buttocks and face. Those are all very sensitive areas that we have to keep in mind when we're choosing medications because of possible side effects. And then patient comorbidities. So what does that mean? So patients that have psoriasis do have increased comorbidities. So can be associated with, like we talked about before, depression, anxiety, obesity, diabetes, inflammatory bowel disease. Oftentimes patients will have with an inflammatory disease, they will often have other inflammatory diseases. Again, so asking your patient, you know, do you ever have bowel issues, any eye issues? It's very important to do a very thorough history with your patients because you can identify some comorbidities, and working with your primary care is really important as well. Number of applications per day. So if you have a patient that has to apply something a couple of times a day, you have to think about that patient specifically, because, you know, some people have very busy lives, and truth be told, many people won't put a cream on twice a day. So you have to be realistic about if that's something that that patient is going to be able to do per day. Twice a day, if that patient says, you know what, I can only do it once a day, you really have to take that into consideration, because adherence is very important. So listen to your patients. Some pharmaceutical companies will take, again, special sites into consideration for coverage, which is wonderful. So like we've said before, some of the insurance companies will make you sort of try and fail other less expensive medications to get you more expensive medication. And some of these drug companies will be able to offer that if you've got some, you know, involvement with the face or genitalia due to decreased quality of life. So working with your care team, definitely we always want to create a very open, honest relationship with our patients, but it's really important for patients to be able to feel like they can ask us anything, they can show us anything. Bringing a list of medications is really important. Oftentimes, you know, we have our GP say, please have the patient bring your medications, but bring everything with you. Bring it all in a bag. We'd love to see it. We'll go through everything together. And what you've tried, certainly we don't want to give you something that you've already tried and failed. Again, there could be a cost issue there. So it's really important to bring your medications with you. And be prepared to discuss possible comorbidities. So there are some topics which can be difficult to bring up with people, but it's really important to have a really open, honest conversation. So if you have a patient that is dealing with obesity, you know, we have to work together, because those issues are very important to discuss, because it can create more inflammatory cascade, I guess would be the way to say it. Some patients do need more workup. So if you're having a patient that's going on to systemic therapy or biologic agents, oftentimes we'll do some screening, blood work, chest x-ray, TB testing. We just want to make sure there's nothing going on in the lungs, your blood work is all normal. It's also a really nice way to identify maybe there's a reason why a patient can't take a certain medication because of elevated liver enzymes, or depending if it's male or female, there's lots of reasons why we would do sort of a screening workup. And majority of our patients, if we're going to transition from topicals or phototherapy to oral or injectable medications, they will have that screening, blood work, chest x-ray. So discuss your goals with your treatment care provider. So it's really important, again, as a patient or a family care member, talking openly with your provider. What are your goals? So, you know, if you're somebody that's on the road 5 days a week, you're a truck driver, obviously phototherapy is not going to be conducive with your lifestyle. So it's, again, really important to keep your goals in mind. And, you know, I always say to patients, I think it's great, write down what's your goals for today. You know, we're happy to listen, and that's how we get the best sort of treatment plan, is if you're honest and open with what your goals are when you come to the clinic or any clinic.
I would say that in most cases, for patients who have basically any form of psoriasis, whether it's mild and just, you know, spots affecting elbows and knees, or whether it's very significant, like 10-15% body surface area involvement, it's never just like a one visit and you're done sort of thing. So it is a continuum of time. We often meet each other several times just to ensure someone's responding to treatment or to move on to another step of the ladder. So sometimes that first appointment can seem a bit overwhelming, because maybe you've never heard the word psoriasis before, or we're talking about so many different medical terminology and the need for all this testing. So just think of it as, you know, a relationship that's going to grow and evolve over time. And it's not just a one-sided relationship.
Absolutely.
It's kind of like a treatment triangle, you know, so it's the physician, the nurse, the patient, their family members. So it's a relationship. It's not just one-sided. And again, if we don't ask about your goals for a treatment, then we'll never know. So I think those are some really nice key points to take home and to bring back when you're going to see your dermatologist or skin specialist next.
And also, I think it's really important, and I say this to all my patients, I think it's really important to understand that when you're coming into the clinic, as a provider, we're not expecting you to know all the treatment options, and we're certainly not expecting you to, you know, at the end of the day, make a decision in 5 minutes. Sometimes that's very difficult. Oftentimes patients are ready, you know, they sort of take what we say and they run with it. But it's okay if it takes you a couple of visits. I can say in the 15 years, there have been many patients that I've treated for years. I can think of several patients who started off in phototherapy and came for years, and was very, very apprehensive in starting any medications by mouth, certainly by injection. So it often does take a little bit of time to build that rapport and trust with your care provider. So it's okay, you know, if you're nervous, I have to make a decision at the end of this appointment. That's not the way it is. It's, you know, we're happy to see you a couple of times.
I think all of us would rather everyone be on board than to write a prescription and not know if it's ever going to be filled, or the patient just never comes back. I think it's better to be on the same page, and we definitely understand it's a big diagnosis. There's a huge option of treatments, and it's very overwhelming. So that's why we often book people back within like a month or so. Yeah. And that kind of brings the end to our talk, but we're definitely open to lots of questions. I know our chat has been kind of filling up with lots of questions from our audience. So feel free to
Thank you.
ask.
Amazing. Thank you so much. I'm always impressed with how much information can be put together in such a short amount of time. And you did a great job of walking us through that and making the examples very real, because you are seeing patients every day. So thank you so very much for that. And we have a lot of questions, which is fantastic. So we're going to get to them all. I thank everyone for their patience. To your points that you ended on, it's really great to hear both of you encourage people to ask those questions and to feel confident in sharing what's not working, right? Because we do encounter that a lot. People give up because this is a chronic disease and it takes time to find what works for you, and that could change, right? So really encouraging to hear you say that and to remind people that it's like a dual relationship. So yeah, okay, I'm gonna dive right into some questions, and then we'll I'm sure more things will come up as we go through these. So one question, so I'm kind of going to go in order, was about phototherapy. This is a common one that people may encounter as an option. One question was about any long-term risks. Can you speak a little bit about long-term risks with skin cancer with phototherapy, please?
Go ahead.
Oh, I'll just say from my training, I trained in Ottawa, as you mentioned earlier, and it was a big phototherapy center. And so we had all those types that I mentioned in Ottawa. So we had the narrow band light, UVA light, and the PUVA with a bath and tablets that you take before. So lots of different options. And I tend to think of UVA as the highest risk. And so those patients were limited to 300 treatments, which is a lot, but that one has a higher risk for, skin cancer development and photoaging. So that one was limited. We don't really limit patients to narrow band. We do tell them, like once they're clear or almost clear, then a lot of patients either take a break from phototherapy or go into maintenance. So they stop coming 3 times a week and they go down to once a week. So we do try and limit their exposure and only the affected areas. So a lot of times patients cover their face if they're not treating facial psoriasis to limit the amount of sun or phototherapy they're getting to those key areas. But theoretically, yes, there's a risk.
Thank you. And the next question has to do with phototherapy as well. So if you can speak to what is the difference between phototherapy in hospitals and when people who buy phototherapy for home, so like small size, so home phototherapy units, and how long to use it, for example, only a few times in lifetime. So maybe if you could talk about the difference between hospital phototherapy versus at-home phototherapy, if there's any distinction there.
Number one would be cost.
Yes.
So the units that are in hospital and the units that are in medical clinics are usually like $100,000 to $200,000. They are super heavy, super expensive, and no insurance company would ever pay for that. And they're serviced regularly and that sort of thing. The home units are more affordable. They're usually broadband light, I think.
Yes, most of them are broadband.
Yeah. So, I mean, the pamphlet that we usually give patients or the website that we direct them to is called Solarc, and you can learn a little bit more about each of the different varieties, but I believe it's more broadband, meaning it's UVA and UVB. So
our clinic is only UVB.
And it's ours is narrow band UVB, so it's actually just a tiny little spectrum of UV light from 311 to 313 nanometers, and that's supposed to be the safest and most effective for inflammatory disease. But definitely there's a role for these home units.
Great, and thank you. And yeah, I guess it's getting, again, evolving to be safer and safer in that respect, right? I just want to quickly mention that we do have some information on phototherapy on our website too, and we're adding some more. So it's a source of information on our website as well. And that CPN has advocated for access to home-based phototherapy being covered by provinces and territories. And actually in Ontario, the Health Technology Assessment Body that reviewed home-based narrowband UVB phototherapy gave it a positive recommendation as something that it would be valuable for government in Ontario to pay for. So we continue to advance advocacy in that way too, because like you both mentioned, access to a clinic can be very hard depending on where you live. It can be very inconvenient. So just wanted to mention some of that too, so people know what work we're up to in that regard.
You can utilize natural sunlight too. Some of our patients who don't have access, you can utilize natural sunlight. We just say keep it very limited, usually no more than 10 minutes to exposed areas, and then obviously cover up. But that is an option as well.
Great, thank you. And quickly, sunscreen, is it the same application for people with psoriasis? The same instructions, right? In terms of cover up every day. Okay, great. So we're moving on to a question about oral systemic. So this is a general question, but how many days should be given to it's topical. How many days should be given to a topical steroid to take effect before we try another one? And again, knowing everyone is different. And
so everybody's a little bit different, but typically we do like to give it at least a couple months. Like most of our patients, we'll see them back 3 to 4 months later after prescribing topicals to see how things are going. Some people can be very fast responders. I mean, we've had patients that have said, I've used topical Dovabet for a few days and the plaque started to thin out. So you can have a very quick response with topicals. It's not the same for every single patient, and certainly different areas of the body are going to respond a little bit different, especially given the amount of plaque or how thick the plaque is. It could vary with the topicals. So that's why we kind of give like a general range, usually 3 months before we really make a decision on whether or not it's been effective.
Yeah, before switching, I agree with 3 months. And definitely some agents can be more irritating at the beginning when you start them, especially in these sensitive sites. And so we often tell our patients, like, don't give up. It's usually irritating because the skin is so sensitive to begin with. And so we try and get them to push through or come up with ways to make it more tolerable, like keeping their medication in the fridge or that sort of stuff. And then reevaluating at like the 3-month mark. Yeah.
Great, thank you. And that, again, I want to reiterate, like it is so easy to give up when you think something's not working, and especially with a chronic disease. So, so thanks again for making those points, and again, the importance of having that relationship with your medical team, so that if you are worried or you're concerned about something, you know, it is an email or a call or some follow-up that can help reassure people. Quick, okay, this is a little bit unrelated. So you know, given that the topic isn't on this tonight, please feel free to, we can share information afterwards, but comments on COVID vaccine and psoriasis. Any comments there? I know there's anyway, I'll leave it to you to say if you have any points that you wanted to share at this point with the COVID-19 vaccines.
Yeah. Big topic.
Yep.
We definitely,
every time.
Yeah, but you know what? Almost every visit that we have or every phone call that we have, we end up talking about it.
Yes.
So in general, we recommend the vaccine to everyone. All of our psoriasis patients and all of our patients who are on all the medications that we talked about. So being on those medications isn't necessarily a reason that they shouldn't have the vaccine at all. In some cases, we used to tell patients that they should hold, you know, methotrexate or cyclosporin, like some of these more traditionally immunosuppressing medications, a week before and a week after their vaccine. But I think more recent evidence has come out saying that there's no need to hold, just get the vaccine. And these medications also form part of the list that's come out from our Ontario government anyway of potential reasons why someone could get a third COVID vaccine booster. So we've been giving out forms to our patients for them to take to, you know, a vaccine clinic and get it. But I think it's been made very easy by a lot of vaccination sites where you can actually just bring your bottle with your name of the medication on it, and the patients will receive their vaccine quite easily. So we've definitely been recommending it for our patients. Yeah.
And flu vaccine every year. We've always been recommending flu vaccine.
Yeah. Great, thank you. And we are keeping our, again, I'm just adding in case it's helpful to people, on our website, we are keeping our COVID section as up to date as possible. So, you know, different provinces have released information about third shots for certain populations. So that information is public. We're keeping it on our website as well. And it's another good webinar topic, I think, to follow up and eventually do another one, follow up to some of our past sessions that we've done on this topic. So great questions. Okay, so looking at these questions, another one that we get a lot is around diet and psoriasis. So I am going to pose it because when we were promoting this event, that question came up a lot. So again, we have an entire webinar on this topic that's pretty recent from last year. You know, we know there's no cure for psoriasis, so there's no, unfortunately, we wish that there was something, but any comments on diet and psoriasis from both of you as you, like in your work with patients and how you support people who have questions around diet?
So from the nursing standpoint, I would definitely encourage, I mean, everybody, but particularly people that have inflammatory disease, very healthy lifestyle, diet is very important. So, you know, we would just recommend, you know, limit sugary foods, eat, you know, high protein diet, lower on the carbs, just to maintain a healthy weight. Again, you know, obesity and psoriasis is, you often see that going together. So we really advocate for really healthy lifestyle with all of our patients, but particularly with inflammatory disease. Has there been any evidence that you can speak of, Dr. O'Toole, with certain medications, or sorry, excuse me, certain foods being inflammatory. I know a lot of people.
I think there's a lot of interest in
Yes.
that. There's some evidence that's coming out in these inflammatory conditions where there's support for this diet that's called the anti-inflammatory diet. I know in another condition that we treat a lot called hidradenitis suppurativa, that has been well studied, and so that's been highly recommended, and I've seen patients that have responded well. And it's nothing bizarre, it's just certain foods can increase inflammation in the body, so it's just avoiding those high inflammatory foods, which basically is what Julie said, just eating healthy, healthy fats, high protein, low sugary processed foods. But yeah, so I don't think there's no like one food, if you eliminate your psoriasis will go away. But it's trending toward these healthier lifestyle, healthier diets.
And you can purchase like low inflammatory cookbooks.
Yeah,
I know I have one myself, but any anti-inflammatory cookbooks are available if people are really wanting to really kind of shape their diet and they really don't have a starting point. That's an option too, to kind of get you started.
Thank you so much. And again, this is a topic we'll continue to bring. It comes up, as you know, and as it should, because it's hugely important all the time. So we'll definitely have updates on this as well, on this topic.
A lot of patients will ask if, maybe they're hoping, and I mean, I wish I could say, just don't eat any sugar and your psoriasis will melt away. I wish that was the answer. And I do know that we have a lot of patients when they come in, they're like, okay, if I just stop eating this, does citrus foods aggravate my psoriasis? So I think a lot of people when they're coming in, they're really hoping, and I wish we could tell them that just eliminating certain foods from their diet could cure psoriasis, but as we know, that's just not the case. And certainly in the 15 years I've been doing this, there's never been something I could say, okay, if you stop eating tomatoes, you're not going to have psoriasis flare. It's just not. It's not as simple as that.
Yeah, absolutely. So thank you for your perspectives. And again, if participants haven't checked out the video or the recording of the webinar we did on diet and psoriasis last year, it's still posted. So there's more, they go more in depth into this conversation, and we will have updates on this because, research evolves and we'll continue to keep learning as we go. So a question specific to the genital area and treatment with topical vitamin D. Can it be applied on the labia minora, not in the vaginal canal? Can you speak to that at all in terms of safety with topicals?
Yeah, so it sounded like the person was asking about topical vitamin.
Vitamin D,
Yeah, so vitamin D comes on its own. That's called calcipotriol, or the brand name is Silcus, and that's very safe because it doesn't have any steroid in it, so it doesn't run the risk of thinning the skin in such a sensitive area. In some patients, it can be irritating, so I would always warn them about that. But in general, it can work quite well. There was a bit of a problem with back orders in our area for getting calcipotriol. It's also not something that's covered without insurance. I tend to have better success either with a topical calcineurin inhibitor, something like Protopic or Elidel, or a lower potency steroid, something like Desanide or Hydroval. So ones that are steroids, so they're still anti-inflammatory, anti-itch, anti-scale, but they have much less thinning of the skin. So those are my go-to for genital areas.
Thank you so much. And again, there are a lot of questions here, so really appreciate that we're kind of jumping around at different topics and you're being very patient as we go in order. Yeah, it's a great group. And there are a couple of questions about specific medications. And I just want to acknowledge that because this is a general presentation, we don't typically answer questions about specific drugs. because everybody can be different in terms of side effects and in terms of like how they respond to a treatment. So I'm going to just respectfully acknowledge those questions and encourage people to check out our treatment section on our website. Some of questions around side effects, some questions around, we have like very simplistic information from product monographs that are easy to access on our site. So you might get some info there, but of course, please ask your doctors, your nurses, your healthcare team, if you have questions that are important to you. So another question is about over-the-counter moisturizers for plantar psoriasis in between prescription topicals. So the question is framed as, do you have a recommendation for moisturizers? Not to mention anything specific, could you give us some input into your perspectives on using moisturizers on some of these more sensitive body parts that are not necessarily prescription treatments?
Yeah. So, I mean, any moisturizer, any topical that's over the counter is going to be safe. Again, when you're choosing something, so think about when you're in the supermarket or wherever you're going, pharmacy area, there are so many options. It's very overwhelming. So again, as a nurse and a consumer of product, I kind of tell my patients, you know, when you're choosing something, think about the location. So if it's your hands and you're choosing a moisturizer and you're a cashier, you obviously don't want your hands really greasy. So a lotion has a lot of water, and that's how it kind of gets up through the reservoirs to pump it. So a lotion sometimes is a better option. If you're at the cashier, you just have to kind of moisturize quickly in between transactions. So lotion might be a better option because it's a lighter formulation. A cream or a balm is going to be a heavier product. If you're really wanting to moisturize, say, the bottom of the feet that's very thick, I kind of say you want to choose something that you can scoop out. So that tells me that there's not a lot of water content in it. It's a bit of a richer product. So it will certainly be more hydrating, especially when you're dealing with that really thickened tissue on the bottom of the feet.
I would say a lot of patients tend to use the thicker products like heavy creams or ointments with like a Vaseline kind of consistency at night.
Yes.
And then in some cases they like wrap or even like wear
Occlude the area.
white cotton socks and gloves for their hands and feet. And that really makes it penetrate better. So sometimes they can get through the day with like a lotion or a cream, but then use something thicker at night so that it's working overnight.
That's amazing. Like that was like the best way that I've heard it described. Julie, thank you so much too for like walking. I mean, at least for me, I don't know if others have had that breakdown, but that was super helpful and clear. So moving from the feet to the scalp, one question we're getting here is, how do you manage scalp psoriasis? And what if you get liquid that comes from the patches, which I can imagine sounds very frustrating. And I'm going to add one more tag on to that out of like questions we get. But is there a difference too in terms of like hair texture? Because we know, you know, different skin texture, different skin tone, different hair texture. Any recommendations around treatment that you want people to encourage people to think about? Sorry, two-pronged question about scalp.
It is, yeah, it's kind of an art treating the scalp or hairy areas on the body, because that's kind of the last place someone would want to put something greasy like Vaseline all throughout their scalp. So knowing where you're treating and what type of hair it is. So the scalp is a nice place for something that's like a lotion. So something that's kind of liquidy based that you can put on and it spreads easier. It doesn't leave like a thick, greasy residue. So that's been a popular choice. And there's some agents out on the market, combination or just a topical steroid that work quite well for the scalp. And then
or a spray,
a gel is nice. So one of the versions of Dovabed out there is a gel, and some women and men love that for the scalp because again, it doesn't leave like a sticky residue. A spray, like Julie mentioned, that a lot of our female patients like sprays for their scalp because again, it's not leaving a heavy, greasy residue. So it's really kind of working with the patient, what type of hair they have, how often they're going to use it,
how often they wash their hair,
yeah.
because that's invaluable information too. And also counseling people on how to get product out. So if you've got someone that has used a lotion and it's, you know, it's all through their hair, it can be really tricky getting it out. So I usually tell people you want to put your shampoo on dry hair, massage it in, and then have the water over the head, because otherwise it's like oil and water. It's very difficult to get out of the hair. So that's something to consider too. And that's certainly where my role comes in as a nurse. I really like to add those just little tiny pearls, because it will increase adherence to a product use if you're counseling people on how to use it, how to get it out. And again, it's so important for patients to be able to let us know, okay, I only wash my hair twice a week. So I want something that's going to be easily washed out when we make our decision on which topical we're going to choose.
Yeah.
The texture of the hair, I'm not sure that that's really relevant. I don't think that I would choose anything different based on the texture of the hair. Maybe if you had somebody that had no hair, that would be maybe important, because they don't want it sort of their head looking glossy. Possibly that would be the only time I'd really think about, okay, what's it going to look like on the scalp? But
or sometimes just asking a patient, like, what do you think you prefer more, a gel, a foam, a spray, and then working with them, because that way they're playing an active role, and they're the ones going home with the prescription, not us. So that is helpful.
Using an ointment on somebody that has a lot of body hair is probably not the best idea, and most likely a patient will not use it. So that's, you know, if you didn't look at your patient and they're just reporting I have psoriasis on your back, and you haven't, you know, had a look, and that patient has a lot of body hair, and you prescribe an ointment, I'm guessing they're not going to use it, because it'll stick to the hair and it will feel uncomfortable and it get on their clothes. So it is really important. It's multifactorial, really. Examining, asking. Yeah,
absolutely. The skin is amazing, and you know, it is like every individual has got a lot to consider. So those are great points. So there are more questions. We have a few more minutes before we have to kind of wrap things up. So I'm going to ask a couple more questions. Just before I do, there are at least two questions that I see about people who live in different locations. One is Thunder Bay and one is Calgary, I think. Oh no, Southern Ontario City. Okay, sorry. I don't know where I saw Calgary. I might have seen Calgary in another question. Long story, people are asking like how they could access a dermatologist or a clinic in their location. Because we can't really get into these questions specifically on this, and you know, geographically, we'd have to kind of like look to help and see how we could help you. I just want to remind people that on CPN's website, I keep referring back to it because it is the point of contact for all of us. There is a contact form for questions, and I actually get all those questions. So for people who are looking for a dermatologist in any given location, if you reach out to us, we can direct you to a tool online at the Canadian Dermatology Association website, where you can actually put in your postal code and you can find dermatologists near you. We could also provide some general information about, you know, what wait times look like, or what to do if you're not finding the right match for you, or what to do if, you know, you're struggling. So I really encourage anyone who's posed a specific question about where to please reach out, and we will do our best to give you the information that we have to help you find someone who's as knowledgeable as these two are all in Peterborough, unfortunately, and can't be everywhere. And then I guess the last couple of questions about the actual topic. How would you support somebody who's losing their hair because of scalp psoriasis? That can be very distressing, I'm imagining. So any comments or ideas about that?
Well, I think certainly somebody that's losing hair, obviously the main goal is to reduce that inflammatory pathway. So treatment as soon as possible. And that hair should grow back. That's the one sort of reassuring comment I'd like to make. Some people that do have thickened plaque, if they're combing their hair, they will find hair coming out from the plaque. So again, just treatment as soon as possible, hopefully can interrupt that inflammatory pathway, and so that the hair can grow back. I don't know if there's anything else you want to add to that.
No, I agree. It's definitely sometimes reassuring to patients to tell them it's not a scarring type of hair loss. So once the inflammation is calmed down, it will regrow, which is always nice to hear. And then I totally agree. So just aggressive early treatment, early intervention, sometimes prescribing a topical, but at the same time, offering, do you want us to inject it today? We'll just slow things down, and get treatment underway. So just kind of being a little bit more aggressive, if the patient's up for it, for managing it.
Thank you so much. There are some questions that are outstanding, but what I will do is look at this content after the fact, and I think we could probably have a whole other webinar on this topic, or on some of the topics that came up. I thank you so very much for your formal presentation, and for being so willing to share in the Q&A. That was very active and engaging. So thank you so very much again for joining us.
I did want to add one thing, just to mention about like point of contact, how to get in touch with a derm. So if you don't have primary care, say you don't have a family doctor, there are other ways that you can obtain care. So Dr. O'Toole and I were talking about this earlier. So some places have like urgent care clinics, a walk-in clinic. Some places can have telemedicine programs that you can utilize. Some places have like nurse practitioner clinics only. So there's, pediatric POP clinics that can be utilized. So there are other ways to obtain a dermatology consultation, even if you do lack a family doctor, which unfortunately many people don't have primary care. And so sometimes they feel like they're at a loss, like, what do I do? Where do I go? So there still is help. There still is access that you can gain to receiving dermatology care. It's just navigating, where to go. So there are options for sure, even if you don't have family doctor.
Amazing, and thank you. And again, please contact us, because there is some of that kind of information on our site, and we can help with the specific questions. We do our best anyway to try, because it's true. It's family providers, unfortunately, aren't. It's a little bit of a luxury sometimes, depending on where you live, sadly to say. Thank you so much again. I want to thank all of our attendees for your patience earlier this evening, for your participation. Fantastic engagement as always. I want to remind people that our evaluation will come out by email, so we really encourage you to please let us know how things went for you. Also, we hope to continue doing webinars like this. We want to thank our sponsors for enabling us to put this work together. And with that, I want to just remind people that if you missed any parts, this will be available on our website, cpn-rcp.com, in English and French in the next few days. And please stay tuned for World Psoriasis Day, everybody. Friday, October 29th. We're going to be really active on social media. We've got t-shirts going out to clinics. So everybody will be raising awareness, and we've got a great report coming out. So yeah,
we're probably going to get t-shirts.
And you can send us your pictures and tag us. And thanks very much, everyone. Again, it's always a pleasure to put these on. So thank you.
Thanks for having us.
Thanks for having us.
Good night.
Right.